there we go. We're better. Good morning. How you doing?
Right yourself.
I'm good. Okay. You sounded choppy when you spoke. Wait a minute. See, you was doing so well.
Headphone. I thought they were connected, but they're not.
You hear echo?
Says they're connected, but I can't hear anything through them. How about now?
You still sound choppy, and then wait, hold up. I just heard
Okay, I know what it
reverb
is.
now. See, I learned a new word, reverb.
So I'm everywhere.
Okay. Did you figure it out?
Well, it says it says my headphones are connected, but I'm not hearing anything through them. I'm only hearing it through the speaker.
But I hear you. We hear you. And you sound better. I don't know what you did, but you sound better. You sound much better. Cool.
All right, go ahead.
Well,
It's
good
9
morning.
o'clock.
Good morning. How you doing?
I'm great, and yourself?
I'm good. How was your week?
It was good.
Okay. I'm sure you have much more to discuss regarding your week, but we'll get to that. So
no, kind of. It was kind of blah. Nothing fancy.
No, not blah. Okay. Well, welcome everybody to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurial. I think I got to expand my whole list. I say that every week. I need to expand the whole list because we talk about all the things. We spill the tea on all the things. I'm Clarice Warner. I am the Girl with the Pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And before I introduce my co host, today's episode is brought to you or sponsored by the Professional Reimbursement Network's free email course on the 5 steps. Yes, there are 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Hey, all right. See, I'm jamming. I'm the music. I don't know what's got it to me today, but all the music is capturing my spirit. So
Good.
if you are on Clubhouse and want to join in, and be a part of the conversation, please raise your hand. Don't be shy. Your opinion matters and is welcome here. And for my Facebook and YouTube friends, feel free to add a comment. Also, let's see. If you are interested in the information on the 5 steps to become a certified marketable medical coder, and you are on Clubhouse, make sure you check out the link at the top of the house, also, or the room. Also, for YouTube and Facebook, check the video description for the link. There's information there. So, joining me today is my co-host, Mr. Jesse, the registered trademark, the coding nurse. Yes. So, sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia, Pennsylvania. I've been in LPN for 29 years. I transitioned into medical coding in 2014. And during the pandemic, I created a company called the Coding Nurse LLC, where I help other nurses transition away from the bedside into the world of health information management.
So let me give you a little tea. Did you know that CMS has some sort of newsletter that's geared specifically to nurses? There's a nursing. I stumbled across that.
I had no idea.
Yeah, I'm gonna find it and send you the link. So I'm jumping ahead, I know, but I was out there looking for something, And you know how you sign up for the different it might be even a blog. You know how you sign up for different listservs and blogs or whatever. Well, in the whole list, if you go through the whole list, there are things geared specifically for providers. And so there's either a blog or a newsletter or something specifically for nurses. You have like non-physician practitioners, but then there's something that's just for nursing. And I was like, wow, okay, they talking directly to nurses. All right. Okay. So I don't it could have been out there for years, but you know how nobody ever tells you anything. You just gotta
Right.
find it yourself. So
Right.
so I found it and I'm telling it. That's my first tip for the day. Okay, Mr. Jesse, Mr. Jesse. All right. So today I think we got a trend going here with these articles today. One is kind of a good trend and some opportunities that can fall out. But the other one, maybe not so good for providers, but good for individuals, huh? So, um, let's see. The first article that you had, and I'll credit Mr. Jesse for our articles this week. He was the man. He was the man. He was doing the thing. All right. So the first one is dealing with a topic that we've kind of been talking about for the last couple of weeks, Medicare Advantage audits and all of the lawsuits and uh, enforcement actions that are happening around um, around these audits. And the one thing, and this article comes from Brian Murphy, and if you are on YouTube and Facebook, the articles are linked in the description box as well. So he talks about, the differences between Medicare Advantage and traditional Medicare and all of the things, and that, it's expected that there will be more people or on the Medicare Advantage plans. About half of the total Medicare population will be on Medicare Advantage plans. And something that we talked about last week is that, but they're spending a whole lot more money. um, it says CMS spends $321 more per person than those enrolled in traditional Medicare. Or looking at that in a wider scale, that's 7 billion, an additional 7 billion in spending. That's a lot of money. So because of that, everybody is all on top of it. What's going on? What's happening? And of course, the organizations and plans and folks are trying to scramble and do and see, well, what's happening? What's the deal with this? And why is all this money being spent? Well, um, it seems like whistleblowers are all the things you talk about. Gatekeepers is the word of the year. Try whistleblower and Keytown. um, so folks are whistleblowing all over everywhere about what is happening with these in different areas, and not all of them are whistleblowers, but one whistleblower uncovers a whole bunch of things and folks start scrambling and folks start looking. And so yeah, and actually they called her a medical records auditor. That's what they called her, from Palo Alto Medical Foundation. And she said, hey, something's not right. And she spilled all kinds of tea about what was happening there. And pretty much just the diagnoses were incorrect. They were adding false diagnoses to the patient records. And yeah, she said she couldn't believe how bad it was. And for all, what'd you say? I'm sorry.
I was laughing.
Oh, she said it was a direct quote. I couldn't believe how bad it was. But for just speaking up, she got a lovely chunk of change uh, as a result of her whistleblower efforts. Um, the one thing from this, and then the article goes on to just talk about all the other places. So that now the OIG has been looking at. And they released a report and they've put it on the work plan and all kinds of stuff. So people have been on notice for a minute, but I guess they just been doing what they've been doing. They talked about Humana, they talked about United Healthcare, Kaiser. I mean, the list goes on and on and on. Now, the one thing that I thought was kind of interesting, it piqued my curiosity, was kind of Kaiser's response. And they talked about the CMS's risk adjustment data validation audits, which I was under the impression was a regular occurrence or something that was happening. Um, I know at least quarterly or at least annually or something.
It is. It's annual. They usually call them like they usually have annual RAV audits. Yes.
Yes. So they're claiming that they had strong performance on their data validation audits, and so some don't add up there to me. So if you got strong performance on your RAF audits, how are you now finding all of these errors and problems with diagnoses not meeting the meat, if you will, and being added and included um, in your score? That part didn't. I can't. I can't wrap my head around that one. Like, well, why are they telling you things are great and wonderful, but they're not? But shed some light on that for me.
Well, first of all, like Kaiser has been. I mean, if you know anything about Kaiser, Kaiser Permanente is pretty much a West Coast based provider.
Correct.
They have been known for nefarious billing and coding tactics for at least 30 years. Okay. Like they're one of those ones that you take what they say with a grain of salt, and Humana is not much better. Seriously, I have
so pretty much this is just they're saying that they had some good RAV scores. Nobody else has confirmed that. And okay.
All this is starting to come about, and this is where we all like we talked about last week. This all ties into clinical validation. That's where they get caught up. That's where they're not compliant with the meat. Because what happens is, I'm telling you what happens. They go on a wild goose chase for codes. They want the coders to code anything. Like I told you the story before, like my last job. They try to pick these obscure HCCs that you can use in addition to other ones. Like they wanted to use HCC, like when people have thrombocytopenia, like when people go through transplants and they're taking tacrolimus, you're going to be diagnosed with immunodeficiency. But immunodeficiency, if you are giving someone proper care, you can pinpoint exactly what their immunodeficiency is, and not this broad immunodeficiency. Because why does someone who had a liver transplant, why don't you know what type of immunodeficiency they have? But they want you to use something broad, and then they try to slip in something special too. So they're trying to double dip. But that's what they do. But they end up, when you get audited, you get caught.
Okay. Well, I can't appreciate. Oops, I forgot. I can't hear you. I forgot I'm muted over there. I can't appreciate that. That was their account. Nobody validated their statement that they received great reviews for their work. So yeah, what other comments? I think that was pretty well, and I see all kinds of opportunities in this, but we can get to that. What other takeaways did you have from? Oh, and the AI piece too. But go ahead, I'll let you talk.
Coming from, in terms of risk adjustment period, it's not going to go anywhere, because this is what CMS wants to move everybody to. Because this whole, what do they call it, value-based healthcare, it's not going anywhere, because they're getting away from fee-based, because fee-based, it has run amok. and it's hard to contain. But what they're going to get these numbers down. They're not going to keep on spending $321 over per person and spending $7 billion annually, because the whole intent was to manage costs, not to balloon costs. So these providers, these companies have found ways to kind of they think they found a back way to go, but they're always going to get caught, because especially now, because you never heard of clinical validation denials. I mean, that was especially in outpatient.
Mm-hmm.
But now when you have these codes, you have people scrutinizing, okay, well, what did you do to treat this condition? Or where's the documentation surrounding what you did for this condition? So
Mm-hmm.
it's causing, because the more codes you have, the more documentation you have to have, and
Mm-hmm.
that's what people don't want to understand. Like I where I worked before, it was it's hard to get them to get providers to document properly. You don't have to write the Gettysburg Address per condition, but you still have to get substantive information to show that it's being properly managed.
And the one thing I used to see all the time, and it would be one of the first questions when I was kind of doing my due diligence and interviewing with clients and prospective clients, is to ask, like, within your EMR system, does it automatically um, bring forward or carry over or carry forward the problem list? Because there was a lot of EMRs that, or people allowing those EMRs just to from encounter to encounter to carry over that problem list and into the assessment. And so it's like, whoa, it then makes the provider, um which they should anyway, but it provides an opportunity for the provider to then go through that list in the assessment and remove the things that they didn't discuss. But 8 times out of 10, sometimes 9 times out of 10, they didn't do that. They just left it there. And so it was included in that exhaustive list of their assessment, when really those things weren't assessed at all. It was just carried forward. And so I would just be like, yeah, somebody, you may want to check that, or provide really, really strong provider education on making sure that those things are not added. One client I had, that they said yes, their list populates, but there's some type of button that the provider had to click in order to have it actually carry to stay within the record. And at that point, they had an option to either click the button to have the things populate over, or there was free text where they can actually put in what they assessed during those encounters. And I was like, okay, I like that free, but or that choice decision making piece right there. But some of them didn't have those options, and it was like, this is a mess. And so if it was something to risk adjustment, all kinds of stuff then populated and cause those scores to potentially be inflated if nobody is checking those on the back end, so, or on the front end before it's actually going out.
And then on top of it, to make it worse, a lot of these companies are using something called NLP. So
The
that's
natural
like,
language processing
yeah,
thing.
processing.
Mm-hmm.
So this is like first level AI.
Mm-hmm.
What they do is they have this system scan all these records. So you'll get, as a coder or an auditor, you'll get a spreadsheet. On this spreadsheet, you might have Mr. Jones might have 17 hyperlinks.
Mm-hmm.
And these are instances where, let's say, diabetes or something came up that could possibly risk adjust, and you have to go in and look at it. The problem with that is, I think statistically they said that almost 3/4 of what they capture you can't use, because right now AI is not, there's no decision making involved. It's very linear. So anywhere diabetes is, it's going to create a hyperlink. But diabetes could be in family history. That doesn't do anything for the patient. Or they have a their father died from a heart attack. well, myocardial infarction. Okay, when you go to click on that link, you can't, that doesn't pertain to the patient. So there's a lot of extra information that does not mean anything to the patient, but the system is not able to filter out yet. But you have these companies who swear by it.
Interesting. Well, speaking of artificial intelligence and AI, they talked about that folks, of course, think that AI is going to cure the world and cure all the ills within the world and fix all of the problems. But they also strongly suggest and advocate for that there needs to be some human connection working alongside these AI tools and machines. And so while the process or the tool that they have for AI to kind of flag diagnoses and possibly, I guess query, if you will, there still has to be some human, to your point, decision making that determines whether or not, the diagnosis was monitored, evaluated, assessed, and treated. Um, so yeah, it's crazy. It's crazy. It's
It
crazy.
is.
And then the other part I thought was like, okay, so here is an opportunity. To your point, there's not a whole lot of outpatient CDI. And I remember when there this was kind of a buzz. Folks were talking about outpatient CDI, but it never really took off like it should have. Clearly, we're seeing all this money coming back. Clearly, somebody needs to rethink that. So there may be opportunities there um, for coders to get into CDI on an outpatient basis, not necessarily. And inpatient, outpatient. There are a lot of different rules, a lot of different things happening. However, CDI kind of are there huge differences within the validation as far as risk adjustment with CDI?
Yeah,
Okay.
because well, it all goes back to the whole value-based system, because they're trying, because if you really think about it, HCCs are not very much different from DRGs
Okay.
when you think from a, a functional standpoint. They
Okay.
pretty much do the same thing.
Okay.
But it's just that inpatient is a little different because, for number one, DRGs are attached to a lot more money.
Correct.
Like, we're talking about like Mr. Jones in a risk in risk adjustment. Mr. Jones might get $3,000 a month for his risk adjustment factor from this insurance company, but Mr. Jones could go inpatient and his bill could be $72,000 after 4 days, based on the acuity of level of his care. So it's it's a lot more scrutinized in inpatient because it's a lot more
And
money
more
involved.
money, right? We always talk about following the money. So yeah, you're right. So maybe they didn't feel like the return on investment was there in order for them to kind of put together and follow suit with these outpatient CDI. But it seems to me that somebody to rethink that. um, the other opportunity I thought was, of course, there's always a coding opportunity again, because someone needs to make sure these things are coded correctly and properly. There's auditing opportunities, internal as well as external auditing opportunities, because someone needs to, at some point, I know folks love retrospective auditing, which I do too, but there's sometimes a need for prospective auditing, and to me this would be one of those cases where you need to make sure things are correct and proper going out the door. And then I thought, here's also entrepreneurial opportunities, because as we've been talking about, you have on the auditor piece, well, you have the coder piece, you have the auditor piece where maybe hey, I have experience in CDI, I have risk adjustment HCC experience. I have all these other things. And that can be a selling point. Um, and then we talked about recently how uh, contracting with the government. Well, I'm sure I know CMS personally is probably not doing these rafts. They're sending those out, and so that's another opportunity as far as contracting with the government and doing some things on your own. So when as soon as I saw it, I was like, okay, all right, I see. I can connect the dots. Ding, ding, ding. I got you. I got you.
I've
Any
been
other things on this?
I've been slowly trying to get you to do HCC all year long.
You have, and I do have. I told you I got that risk adjustment book. Didn't I tell you that? I have a whole risk adjustment book by oh, what's her name? She was like the queen of risk adjustment when it first came out. The book comes from the AMA. Oh, I can't think of her name. Well, when you're talking, I'll go get the book. But anyway, so the second article. Anything else on that article? And anybody have any questions or want to chime in? Again, raise your hand if you're in Clubhouse and come onto the mic. You can definitely add to the conversation if you like.
I just think that anybody, and my advice to anybody in the room who is a coder, it is impossible to do outpatient CDI without knowing the job. It's impossible because that's the new the new payment methodology, and you have to understand. And just having a CPC or having a CCSP, that's not it, because they don't even really touch on it like that. Risk adjustment is a very specific. If you have worked inpatient, you got it, because you know the whole DRG. You know what can increase the DRG. It's the same thing with risk adjustment, but it's on an outpatient basis, and it's you know capitated a little differently. But you cannot do CDI without risk adjustment because that's the prevailing model in outpatient, and that's where the greatest opportunity lies.
It is. You're right. And I think you're right about that because oftentimes, and depending on your coding program, some folks are not even really introduced. So particularly those who are interested in pro fee work or outpatient or getting their CPC, I'll say that you're not necessarily it's a broad gloss over introduction to what actually happens in the inpatient world, and you have to be intentional. My word for 2022, and seek out the additional information on inpatient and understand um the differences and variances. So my book I got is by Sherry Poe Bernard. It's that risk adjustment. Ooh, I forgot. I got a
Okay,
background. So yeah. So I'm on you. I'm with you. I'm with you. I'm with you. But yeah, because I do see, yeah, there's a lot of opportunity in there and pulling some things together and yeah. And if you want more information about what we talked about, you need to check out last week's episode because we spilled a lot of tea last week as far as that entrepreneurial piece. So I'm not going to regurgitate that. You need to look at the episode last week. Okay. So the other article you had and the reason why I say they kind of fall in line is because there's talking about another whistleblower. Like whistleblowers are making money out the wazoo, sir. And I know you had talked about possibly whistleblowing on somebody if they didn't leave you alone. I said, is he trying to tell me something? Indirectly.
Let me tell you, when you were talking about Humana, I was like, I wasn't going to say anything. But the company I used to work for was a subcontractor for Humana. Also, Humana contributed money to help them get started. So,
oh wow,
I looked now. I discovered this when I was doing my research on the company while I was interviewing, and I asked my friend on the inside. I'm like, well, first of all, did you know that? She was like, no. I said, well, do you know if they have a safe harbor agreement? I said, because if they don't have a safe harbor agreement, this is considered a kickback. Oh, she said she didn't know. So you know what that means? That means no, they don't have a safe harbor, and they done left me alone because I was all set. And the kicker is somebody involved is a former U.S. senator.
Wow. Forget TV. We got we got the drama right here in healthcare. In reimbursement in the revenue cycle. We don't need TV. We got all mystery. Look, you keep following the trail. You might find a body or two. Stop playing. Oh my goodness. Wow.
I mean, it tells it out how you can take money from people. You can have agreements, but you've got to let people know this is an agreement we have between us, and it's transparent.
You have to disclose that. You are absolutely correct. You have to disclose that. Wow. The plot thickens. Somebody needs to be writing a book. Look, because this is crazy. This is crazy. I remember, well, in my compliance officer capacity, I remember one year we were at the national convention and a compliance officer blew, and she, had been in hiding, if you will, for forever. And she showed up at that conference that year, and it was like they made room for her to talk in various rooms. Any room that she popped up in, somebody was asking her questions and she was talking. And it was like, because the first thing people would think was you'll never get another job in compliance. Because you spilled the quote unquote secrets or whatever.
Right.
But no, you have a lot of organizations that really believe in doing the right thing and appreciate it. That the message may have gotten stuck. So again, a gatekeeper kept the information to themselves and didn't give the information to the top, who would have had a different course of events happen, who would have directed them to, hey, wait a minute, we believe in compliance, we believe that we need to take a look and correct and whatever, versus somebody who kind of stopped that and was like, oh no, we think we're good, let's keep doing what we're doing. And so that was amazing, and it was also refreshing to hear that there are organizations that do believe that compliance is important, and they listen to their compliance officers and welcomed even a whistleblower compliance officer. So that means you'll be on your toes, dotting all I's and crossing all T's. But then you have to again look at the flip side, because there are still so many who be like, whatever, we want that money, we're gonna do what we need to do to get that money, and think that they may be under the radar and won't necessarily get caught. But as we have seen, I don't know if I've ever seen a compliance officer. Yes, I believe there was a compliance officer that has been involved in some investigations. So yeah, nobody is exempt from the government. No. When they come down, they coming down. So nobody is exempt.
That's right.
Okay, I see we got questions.
I don't like. I have a slightly different, more jaded opinion. I don't believe that most of these companies want to do the right thing. I don't, because
it's about the money.
Right. And what they do, what I've also realized is that the bad actors move around and they end up getting positions at other companies when things start to get rocky, and they'll leave and they'll get another position, because and they bring that same mindset. Like they don't get better. They don't think, okay, well, because the thing what has always amazed me is, at least here in America, you don't have to fudge anything. People are sick.
Exactly. You have your customer, your patients, your patient mix. It's there. We hear all the time about the numbers of people who are um, diabetics, hypertension, obesity, all uh, on opioids. All of the things. So you got a huge mix right there that definitely can keep you in business for years. So I don't. I'm like you. Why jeopardize that? Why do that? Mm,
Exactly. But read,
yeah,
because at that time, if they can increase, RAF scores, if they can increase revenues, and guess what? They increase their bonuses because they could show how they increase. And the companies are all about numbers now. They don't think about, well, what's going to happen in 2 years or 3 years when we get audited, we have to pay this money back. They
right,
don't think about it because they're in the moment.
right.
And then some of them have already figured out, okay, well, when that happens, I'll be going anyway, because they already got a plan.
Mm, mm, mm. Well, this whistleblower, is it a lady? I said lady, and it might not be a lady. This whistleblower was talking about telehealth and telemedicine fraud and abuse, and they earn a lot of money,
Mm-hmm.
a whole lot of money. Um, but yeah, it's just making sure, and um, the thing is being careful because we're kind of in this we're still in this strange time because we're still technically in the public health emergency, and so a lot of the rules have been relaxed as a result of that. um so some folks are real relaxed.
But they only relaxed a little bit. It's not like it's like the OK Corral.
It's
Like we
not, but things that they are allowing, they didn't allow at all before.
right.
So, that's where I'm meaning as far as relax. Because like you couldn't telephone, no, you couldn't do that. Your iPad, your cell phone, no, you couldn't do that. Those you could not do that with any well, I take it back. You could do whatever you wanted to do. You wouldn't go get paid for it. How about that? So so the payment for things are they're allowing payment for things, and they've relaxed some of those. Plus you have the issues with cross state and cross border providers. So it was a whole bunch of stuff that due to the pandemic that you would have never thought would have been possible or would have ever happened. um but yeah, so this person was like, wait a minute, I'm seeing some stuff that's happening in telehealth and services being misrepresented, um calling things types of services that they shouldn't be, that to get a higher reimbursement, i.e. upcoding. um without necessarily having the documentation to support, billing for specific services not offered, and even kickbacks being paid to healthcare providers for recommending or providing services that weren't necessary. So yeah, it was all.
They same thing in home health. They they do the same thing to increase the reimbursement, because when they do a lot of people, a lot of nurses, when they do their initial home care assessments, they will underscore somebody. So when they do their 60-day reevaluation, they can show some improvement so they can continue home care. And I think that's why home health is changing over to, once again, a value-based program with the PDGM, because some people are not going to get better. Some people, whatever level they are on admission, that's the level they're going to be until they check out, because they just have a lot going on. Everybody can improve. I mean, can you improve a pressure ulcer? Oh, absolutely. Or hopefully you can. But certain other things, no. Some people, they're never going to walk independently again.
Vicky agrees with you. She says that most companies will not do the right thing because it's about the money. I tend to be a little more optimistic, but I appreciate that they won't do the right thing because that means job security or career security.
And from my understanding, like the largest whistleblower settlement I've heard of happened in 2017. This whistleblower who worked for the New York Health and Hospital Corporation. As you know, surprisingly, healthcare in New York City is really good. Especially if you have no insurance, they have public hospitals, and their public hospitals are good. Matter of fact, Bellevue is one of them. That's where they take the president if they need service in New York City. So they have some pretty good hospitals. I mean, public hospitals. But anyway, they use eClinicalWorks, and supposedly eClinicalWorks they got some kind of kickback during their software sales or something. And this person dropped a dime, and eClinicalWorks settled with the government, and his cut was $30 million.
Jesus. So that was a large settlement.
Yep.
That was
Their settlement was like $155 million.
Oh yeah. Oh yeah.
And he got 20%.
So the reason why I was side-eyeing the articles that you were sending me, especially around the whistleblower piece, is because in this particular article, they give you some tips on what to do if you uncover fraud. So there's a free paper that the Harvard Law School Forum put out that says the elements of an effective whistleblower hotline that helps you locate hotlines and get more information on whistleblowers and getting your basic questions answered to find out to find out, what steps you need to take in order to kind of move your case through. Tells you to make sure that there are whistleblower firms, legal firms, law firms. So contact them. Of course, they know the facts. They've walked through this with you, and they can help determine, because not all whistleblower cases are actually they actually go through the entire process. At some point, some of them, for whatever reason, the government won't take the case or whatever, and then that kind of stalls and halts things. But if they do, then they kind of walk you through what happens. But yeah, so I thought that I was just chuckling on that. And then of course, if they take on that case and there's an award, to your point, the whistleblower claims up to 30% of that reward. And all I can hear is Too Short in my ear and blow the whistle. That's all. Every time I read this, I'll be like, yes, I see y'all. I see y'all. So, yeah, good to know. Good information to know. Not that I'm advocating for folks to go out there and blow a whistle. However, the compliance person in me says go through the chains. Make sure you document. So if you see something, let the folks know. Let them at least try to correct it. Let them at least do the right thing. But then if things go left and they refuse and they don't, then an opportunity may exist.
Most people are going to go full steam ahead, and they see you.
I'm just saying.
If they see you as an obstacle, they're going to get rid of you and keep it moving.
So again, make sure you document and have copies of your documentation in the event you are no longer within that organization. That's all I'm saying. That's all I'm saying. And Vicky also says yes, she appreciates my optimism. It does give job security.
So
Cool.
I don't believe nobody wants to come on stage this week. Last week was full. We
They
would.
they was hot. They were hot. Look, they probably thinking counting dollars. No, I'm kidding. Oh, that's what's up. So what happened with you this week? You said it was
Well, the only thing is, I started a new coding class.
oh, well that's sir. Not the only thing. A great thing.
Well, yeah, I mean, I am grateful.
Okay.
It's look. I tell you, this is when I tell you everybody is out this summer trying to have their themselves a hot something summer because
They
man,
doing
'cause
it.
people who like they were like, when is it? I'm like, oh, I'm going to be traveling, or and I'm like, well, you know what? This is really the first year, that first summer we've really been out of lockdown, and now, I mean, COVID is still cutting up and carrying because I know more people now who had COVID, who have gotten COVID than when it first started.
Exactly. Exactly.
So I don't get it.
Exactly. Oh, this was another thing I found. So when I that's how I stumbled upon the nursing thing. So NCDs, they CMS they're updating them with the new codes. So the April codes and then the codes that are becoming coming down the pike for October. But this is the thing. Those codes, they're supposedly or supposed to update like the NCD, the transmittals, and all of that information on a quarterly basis. But I guess that hadn't happened at all. And the kicker thing, the thing that I was like, y'all doing this for real? Because there will be some information, and I'm curious to see if they put this line that they had in this information to the max in this in the MedLearn matter transmittals. But they were telling them they don't have to proactively seek out the providers to tell them, hey, codes that you may have been submitting or codes that you may have that we rejected are now able we rejected I won't necessarily say an error, but we rejected inappropriately because those codes are truly codes that should be part of the NCD. So they're not going to knock on your door and tell you, "Hey, you know what? You submitted this, we rejected it, but really it's correct because our stuff wasn't updated." They're not coming to you. In the little line, it tells them, oh, well, if somebody comes to you, then of course you need to do do the right thing and provide the appropriate payment. But you don't have to seek them out. I said, for real? Is that what you're doing? So if you know that you're working in organizations that you are governed by a lot of NCDs, so you know the types of services and types of procedures that you got going on are dictated by some NCDs, do some research. Have somebody kind of walk through those and look at those to say, wait a minute, especially when they start because this just came out. It's effective um I think on the 17th of July. And so do some due diligence again and be on the lookout for those MedLearn matters because they're going to give you information of that they've corrected those things. And it's all of them. It's the diagnosis portion of it and even some of the procedures. And then there was a whole big list of NCDs and I'm not 100% sure if this is connected to it, but a lot of things that are happening in labs. So a lot of lab testing NCDs are being impacted with this. So just make sure if you are a provider or know someone who is, or you're working in or coding for some of these providers, make sure somebody take a look at that, because you
What
could
I
be
do
sitting on
know
money.
is I have audited labs before. Like some labs, you have to actually send in lab values. Like you have to send in, lab reports to show that it's within a range. And I think it's what's the common one? When people have when people are on iron treatments for cancer, I think you have to send in your they have to send in lab work along with their when they get epigen
Hmm.
for it to be approved. I think so. Because I used to, when I had that contract position, I, most lab claims got denied. I mean, and these are not no like, $75 claims. These were like, $1,300, $2,000 lab claims.
Wow. But I just thought it was just like, really? Is this what we're doing? We're not going to tell folks? Um,
But but here's the kicker: these didn't even have these people weren't even seen by the ordering uh, provider.
so how are they getting that
Because it was something shady going on.
out? Like, where they doing that at? See?
You go to see, you had a lab drawn, let's just say in April, but then when I go look in the system, you've never been seen by this provider, or you were seen a year prior. No.
So the transmittal, if you're interested about these revisions, the one for ICD-10 is transmittal 11453. Again, that's transmittal 11453. And they'll send some MedLearn matters on it. But this is the first introduction to all of the things. And it's a whole bunch of stuff in here. So there's this several tables that tell you like what the actual codes that are being switched over, or what have you. But I was like, yeah, it says, so contractors shall not search history, but shall update any records that submit an adjustment for claims processed prior to July 1st, 2021. And then it says there's something with a modifier Q0. So if you that's with stem cell transplant. So if you're providing those services, um this all the things. I'm like, really? This what we doing? And then there's another transmittal for um the procedures. And I think that is, there's another one 11465, and yeah, there's 11461 6. So look at that whole 60 through 65. How about that? You may run into something. Um, oh, and then this 11453. That's the one I just saw. But yeah, so if you are working in the confines of NCDs, you may want to check that out, and there may be some money somewhere for y'all if they've denied some things for you. Well, good. I'm glad you had started your test or your class, and getting folks ready and prepared and doing all the things. I'm still
Right.
in manual writing hell, but yeah. It's all good. It's all good. It is all good. Let's see what's going on here in the in the Clubhouse.
I saw another article earlier this week
Mhm.
where COVID is now listed as the number 3 cause of death in the United States.
Really?
Yeah. Heart
Wow.
disease, cancer are still 1 and 2, and it increased in 2021 in um, people 45 to 54 and 35 to 44. It went up to it went up to the first and second cause of death in those groups.
That's the majority of the people.
Yeah,
35
well,
to
that's a lot of them.
That's a lot. That's all that's us. Wow. Mm. Wow. Well, y'all know, be careful out there. I know the summer's out here. Beyonce done released her song. Everybody don't want to have their soul broken and all of the good things, but y'all better put a mask on while y'all uh in crowds of people, particularly indoors. I see people. If you outdoors, you got a little grace, but if it's too crowded, I'm on the periphery with a mask on too. Still, like I get nervous. But indoors, nobody is playing with you. And then, oh, this was the thing. Somebody told me this yesterday, or I read this yesterday. Um, it was like, so everybody's saying they got allergies this year. Oh, it's just my allergies. No, fool, you got COVID. Go get a test. Go get a test. And then, but that's the other. People don't want to test. Like, I, why
But
don't
they
you want to know?
all those home tests.
You got a home test. You don't even have to, if you for real afraid that folks gonna call you, follow you, and contact trace you, say test at home. But at least have enough integrity about yourself that if you are positive, if you take your home test and you are positive, at least notify folks so they can know. Just because you may not fall ill or have to be hospitalized or whatever, you don't know who you may have impacted, who they may have impacted, who may be at a higher risk and have worse symptoms. And so, and possibly even that. So I think it's to me, it's just common courtesy. Just tell folks, I'm sorry. I may have been exposed.
Right.
You may want to be tested. Period. You've done your part. Versus, oh, it's just some allergies and I don't want to know and whatever. What the
Exactly.
hell? Who does that? Especially in our community. Come on, y'all. Especially, well, in our community and those who never wanted to be vaccinated and so on and so forth. I mean, we can go on for forever on that, but at least say something. Say something.
Definitely.
Okay, I'll get off the soapbox. My bad. My bad. Oh, so I got a ping that if you are in the South, that heat wave is not letting up, and I guess it's coming back. So if you in the South, be careful. Stay
Definitely.
hydrated. Check on your elderly. Take care of your
That's
pets. Is yeah, that's a mess. And then the thing that I know happens, I know we've had some bad storms over the last couple of days, and folks been without power. So that's another consequence of all of this. You have those rolling outages and outages. So be careful with that too.
oh wow.
Yeah, trees. I don't know. I don't know if the trees is just dry. The trees been falling like pencils over here. It's
Really?
yes. No. After every storm, you're guaranteed some trees, big limb, something to be on the ground. And then
Oh,
actually we had Goshen, Ohio is not too far, but a tornado touched down. So
oh.
there was some damage. Yeah. Yeah. We had a bad storm a couple, was it Wednesday? Wednesday or Thursday? Yeah, so be careful out here in these streets.
We're not even going to mention global warming because that's as much of a hot topic as vaccinations.
It is. that folks just don't get it. Like, at what point do you not realize when it's in the heat or dead of winter and it's 70 degrees? And it's, when we were younger, you would get one or two of those kind of days, like, oh my God, what's going on? Now we get months of that. And folks think it's normal. No. Especially if you were in a place that you see the seasons. You get a good winter, you get a good spring, and forget spring and fall. Them things is blended. We should just have two seasons because most of the temperatures and stuff is just have blended together. So yeah.
And the crazy part about it is, like, where it affects people the most, people aren't aware of it, because, like, when I was in Greenland back in 2011, like during the summer, like summer warm is like 51 degrees. That's like warm as it gets, and that's only a couple days. But last year, because I talked to somebody who had gone back up there, it was like almost 70. So that's a lot of ice melting when it's that warm.
It is.
But ice. That's a lot of ice melting.
And then you got to deal with flooding and the issues that come with that. And so it's a lot. It's a lot. And there are codes for all of that. I see when you be posting your there are codes for that. Things. You do that on Instagram, right?
Yeah.
Okay. So check out Mr. Jesse's Instagram. He posts those. There's a code for that. Memes and pictures. I be chuckling. Like, there is a code for that. Trust and believe. There's a code for all of that.
Yep.
Because coding is just not for reimbursement. Coding is also statistical information and data. So
that external cause index will have you scratching your head like, what? You can code that?
Yes. It is fun just to be going through and see. And the updates, they don't really post a lot of updates to that, but I think they update it. They just don't talk. I mean, I guess it doesn't get the attention as the regular codes do. But yeah, it's all kinds of stuff in there. You're like, what?
And the funny thing is, like, I when in my class, I always give them like two scenarios from the external cause index, and one of the ones I posted. See, that's because they don't. If they followed me, they would have got the answer right, because I posted.
You done gave the answer out on social media. Right. See,
I had the one where the person was kicked by a cow while milking.
Yeah, that's the one with the cow kicking or bucking or whatever it's doing. Yeah.
Now, you should have seen the answers. I got somebody coded struck by an animal. No. You go to the external cause and then you go to kicked. And it says right there, by animal. Kick is not struck. Hit is not kick. Collision with animal is not struck by. But,
that makes it so much fun. You're like, really? What? Just to hear the thought process. But you know what? That is strengthening their processing of that, because especially with ICD-10, you have to think beyond what you think something is supposed to do, especially if you're to arrive at the appropriate code. You got to think beyond that. That's the one thing about ICD that used to drive people crazy, especially when they would go through the index. Well, I thought it would be no, ma'am, and no, sir. So that's a good exercise in strengthening that.
Exactly. Use what's in the scenario to guide you. You don't add to it. Just use what's there.
Let's use what's there. Absolutely correct. All right. Well, y'all quiet this morning, and I guess we're at the top of the hour.
Yeah.
This was good. I felt there was tea that was spilled. Did you have any closing thoughts before we get into whether or not the tea was spilled?
We covered a lot of territory today.
We did. We was all over the place, but it was good. I think it was all relevant.
Because I think what I would want everybody to take away from this conversation, and from what we try to do as a whole, we try to make coders aware that you have to understand reimbursement methodology.
Mm-hmm.
You have to, because that's the only way it all makes sense.
Mm-hmm. Yep. And then and knowing all the pieces of this puzzle, because it's just a big old puzzle. Make sure you understand the pieces. Well, and know the why. I know you hear this all the time, especially if you are any type of creator. They always talk about, well, what's the why? What's the why? Know the why. Why are we doing this? I know you do this because somebody taught you and trained you and all of that, but behind all of that is a bigger why. And know those whys and the rules and the regs that pertain to that. And so we try to provide you, at least I just make sure that you, at least you've heard it. You, if you, if you don't even apply it, you've heard it. And you can be like, you know what? I heard that somewhere. Just remember you heard it on the Saturday morning tea, but you heard it somewhere. And then ask somebody about it. Like, even if you've never, did you know so and so and so? Did you know whatever? Because oftentimes they don't, or they're spoon feeding you information. And like I said before, I like to put my eyes on it and read it for myself, because somebody's interpretation may not necessarily be the correct interpretation, and I need to see it and read it for me, so I know. I say that all the time, and then I tell folks, yeah, you it could be your interpretation, but sometimes your interpretation may not necessarily be correct, and then you're telling somebody else and you're telling somebody else, and lo and behold, you got a whole group of folks that just doing stuff wrong. when when nobody we were in class. I'm taking another health care, ethics, medicine, and law class for public health, and we were talking about one of the articles in the Affordable Care Act. And at some point they were calling it a death panel. And I'm like, we had to look at these news clips and we had to watch these videos of these uh, senators and whatever. And they were just, it's a death panel. They're going to try to kill our seniors. And I'm like, what the hell are they talking about? So like we had to actually read what's on there, and all it's about is having the provider. Well, really, the big premise was getting the provider paid to have the conversation about end of life, about what are your plans for end of life, like, do you have a living will, do you have all of the things put in play for the time that you may not be able to do that. And I'm like, where in the world did they get that the government is now going to restrict care for people, and as you age, and this is I was like, oh my god. And so much so that it caught on to other people, and they was just spreading that word, and they did like polls and all of the things from people. But the crazy part of it is it's along political lines. So they throw something out there and they go another thing, and I was chuckling because I heard it, and I think I've even said it before, and it was like, it's not true about the Social Security, that Social Security is running out, and at some cutoff, and I can't remember what year it happened or they started it and what year the quote unquote cutoff was. But it's a guaranteed something. Now the amounts may vary for the upcoming years, but the benefit is there. It's written in the laws indefinitely. So it's like, wow. So again, you got to put your eyes on the source document. Got to read the source document.
Getting like to piggyback off of the whole death panel thing, because I remember when that was a thing. But what people don't realize is end of life discussions is part of it. That's a HEDIS requirement in the care of older adult measure. You have to ask, do they have an advance directive? Do they have a living? And they want to have a conversation, you can have a conversation, but you have to ask them at least those questions.
And now and so it's written into the statutes that they can be paid for that, for having those conversations, and where they weren't before. So yeah. But again, you got to put your eyes on the source document, because I was like, and I had to submit a response. And I was like, people just don't read. Reading is fundamental, period.
But the media capitalizes on that because they put out, it's so much. I mean, I hate to use the phrase, but it's so true. It is so much fake news out here.
Misinformation, and misperceptions. So much so that you have folks who, and that was the other thing, like uninformed versus misinformed. Like the uninformed, then they can go out and try to get the information, but the misinformed, they're the ones that are out there vocal and feel like what they think or say is right, and they need to tell the world. And it's like, no, check your facts first, please.
Right.
But it's the world we live in. So we are trying not to have misinformed folks in health information. We want you to be informed, armed with knowledge and information. And so that's why one of the reasons why we're coming on here every Saturday giving you the tea. So what's the tea spilled today? Cool. So again, if this information was valuable for you, help you. Help us share this message with others by liking the videos, sharing the videos. Go
Before
ahead.
we go, question in the chat. Tanika wanted to know, Tanika, we'll have to do some research. Says, can we discuss next week how California governor approved a budget for the state to create its own insulin?
Okay, Tanika, you giving us assignments? No, okay. We could do some research on that. That's what's up.
They would want it.
Do you know how much money is in insulin?
Oh my God.
If I was a chemist, no, I'm kidding. If I had a farm, no. It's a lot of money in insulin. That's interesting. Yeah, we'll take a look at that.
Because I haven't even looked up insulin in ages. I mean, do they still make it from pigs?
They did. That's why I said if I had a farm, but okay. I don't fool around with pork. But if I had a farm, I may touch a pig just for the insulin. Oh, I wonder how they. Well, yeah. Let's take a look at that. I'm curious now. Like, how are they doing that? Because I know what the amount of money that I had to pay, that we paid for my mom, for her insulin, and it's no joke.
But then you could go to Canada and get it for pennies on the dollar.
Pennies on the dollar. We're like, I need some Canadian friends. So if you or somebody Canadian or have a Canadian hookup, no kidding, call me.
I read years ago, I read a story that some town in one of the border states, I want to say like maybe Maine or New Hampshire, they have bus trips where all the folks in the town will go across the border. They'll go to this like urgent care in Canada and get all their health care and get all their medicine, and then they come back.
That's interesting.
Yeah.
So they're paying for but it's probably still cheaper to. Now that me, my mind is working. I'm trying to connect the dots. It's probably still cheaper.
Oh, it is.
Then even having to go through. I mean, because what an urgent care visit, depending what it is, and it could be different. The prices would be different there than here.
The visit is nothing compared to the medicine.
To the medicine.
I use two different inhalers. The brand version of my inhaler without insurance is $450. So you tell me.
So you getting on one of them buses? No kidding. Wow. Well, there's another entrepreneurial opportunity. If you live in a border state, contact that. We can figure out who that place is and have some transportation going and all the things. Party planning and nice places to visit while you were over there. See, I see a whole tourism opportunity.
Well, medical tourism is a thing.
It's
now.
a whole thing, especially abroad. Abroad. Yes, sir. We talked about that. We talked about that a couple weeks ago, or a couple months ago, actually, because we talked about the opportunity of learning their reimbursement methodologies in different countries. Come on, y'all. Y'all better think global. Think global. You know anybody with a plane? Can we fly? No kidding. After somebody whistle blow, then we may be able to buy a plane. Okay, I'm sorry. I will stop. All right. So again, you like the video, share the video, subscribe to the channel. You can also check out the Coding Nurse channel on YouTube. And as we mentioned, he's over there on Instagram. We're also over there on Instagram. At least providing some comic relief, if you will. Last but not least, to my Clubhouse folks, make sure that you are networking with each other and following each other. You never know what resources you got in the room. You never, ever know. So, yeah, follow everybody. We're here. You're there. You got some things that your experiences that you could share. So you never know. But last but not least, make sure that you click the greenhouse to join the fun in our club, and you will be notified of our live broadcasts that happen every Saturday morning at 9 a.m. Eastern Standard Time. So this has been a great discussion today. Thank you all for joining. I appreciate you. Thank you, Vicky. She says, thank you for all the bits of information and enjoy your weekend. You too. Thank you. Vicky is a regular on our YouTube. So thank you. Hey, Tasha, I see you out there as well. Welcome. Okay. So again, great session. Thank you for joining. And remember to be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great weekend.
You too. Thanks.